help me because I realized what happened. So whenever I was simplifying this for you, I was supposed to keep going and I had stopped. So where you see the unprotonated, and I'll repost this so y'all don't have to like go back and try to figure out what side and all that. But when you see your unprotonated, it depends on whether it's an acid, right, or whether it's a base because of the natural charge that it's going to have if it's not protonated or protonated. So when you're looking at that, you see unprotonated if it's an acid and protonated if it's a base, you're not going to have the absorption, whereas it's the opposite on our lipophilic side. So protonated if it's an acid, unprotonated if it's a base, it won't have that charge, and then it will be absorbed. So looking at this, we'll I'll talk about it again tomorrow when we do our review in more detail, and I'll have this posted for us to look at it. But I just wanted to address it because we're going to do an edit for that. For our review, it is going to be in class, so it is a required thing that everybody is supposed to be at because it is scheduled class time. Okay. All right, we left off with our mixed action agonists. So when we're looking at these, what we're thinking about is it has some direct and indirect. Don't think of it as like mixed, like it has alpha and beta activity, okay? So keeping them straight in what's going on. So direct and indirect actions to sometimes displace that norepinephrine, our other catecholamines that we have whenever we're talking about our parasympathetic nervous system, or sorry, our sympathetic, but more so we're looking at our norepinephrine. One of the ones that we have that we used to hear a whole lot about, not as much anymore. So you have your mechanism of action, which is, again, our category that we're talking about. So mixed action, and you see that it does just so happen to act on our alpha and our beta receptors. Okay, so alpha and beta agonists, and then it's also doing that displacement. So that's why we have the mix. So seriously, the definition that we saw here is what you're seeing when we're looking at our ephedrine mechanism of action. Just make sure that you're realizing that it's hitting the alpha and the beta. Looking at our clinical uses, bronchospasms, most of the time we're going to use a lot of our other meds that we talked about. Don't really see this as much. So again, this is one of our ones that is kind of down on the list. Where we will see this used, where it's talking about your hypotension, is typically where we will see this used more now. So if you have a patient who you put on anesthesia, we'll look at that. Some of our meds will cause hypotension in our patients. So if we're trying to bring them back up, this is one of those meds that you will kind of see us use in that situation, but again, not very, very common med for us to use. Your adverse effects that you have, you see the CNS stimulation, so some of the similar things that we talked about when we already talked about our alpha and our beta agonists, you're seeing those same exact things here. CV effects with your hypertension, your tachycardia, and then looking at your amphetamines, understand that when you have a person who is active duty and let's say they were admitted to the hospital and something happened where you had to use your ephedrine, make sure that it's documented, make sure that you let them know, because if they were to go back to work and they do a UA, this medication is still in their system, you can get a false positive that makes it look like they're using amphetamines or like methamphetamine, okay, is typically why we're looking at it. Even if somebody was just taking an amphetamine and they didn't have a prescription for it, that's also cause for an issue for them, right? Because they're not prescribed that medication. So if you end up using this on one of our patients, just let them know because there is the potential of that false positive. Looking at our interactions, because I'm acting on my alpha and my betas, I'm going to have those, if they're blocked, I'm going to have an interaction with those, right? They're canceling each other out. Looking at our ephedra, it's banned, so that's all you need to know. You will still hear some people using it. It is illegal in the States, but people will still order them. You know, how you can have online pharmacies and stuff like that. What they were using them for was a lot of like weight loss and athletic enhancers. So,
Jack 3D.
what?
The original Jack 3D.
Oh, Jack 3D, that's what it was called?
It was a pre-workout.
Jacked
Jack.
3D?
Yeah, you got it.
Jack 3D.
It's in 3D. He was free.
I'm sorry, I didn't know that was the brand name of it. Jack 3D. Okay, so no Jack 3D, okay? No ephedra. So understand it is banned. We don't use it, yes.
And was this fen?
It was in a lot of that, yes. And then so what you also see, this is why I don't like over-the-counter meds. They can put things in their over-the-counter meds and they're making claims for them, but we're not as we don't scrutinize or overly analyze our over-the-counter meds until stuff starts happening that's wrong, right? And that's when you'll see like OTCs getting pulled from the market. So people sometimes will adulterate and like sneak things into their over-the-counter meds to make them do something so that people keep buying them. And then we figure it out, just takes a long time, and then they'll yank it from the market, okay? But, yeah. Pseudoephedrine. Now, big caution with this, don't mix up our pseudoephedrine with our phenylephrine, okay? Remember when we were looking at our phenylephrine was direct acting. This is our mixed acting, okay? Very similar indications though. I can still use this to help me with like my congestion, and that's why we really remember pseudoephedrine a lot. So again, our mechanism is the same exact like we talked about with our mixed agonist. Looking at my uses, that congestion. So you will see pseudoephedrine combined with several other products, and when we talk about allergies, we'll talk about this. But it'll be combined with several other products to help if your patient is experiencing congestion. So a lot of times in our patients who have allergies, and congestion is a big symptom that they're experiencing, we'll tell them to, hey, go ahead and get something that has pseudoephedrine in it. It will always be behind the counter. So be very specific whenever you're telling your patients that you want them to get Sudafed. Sudafed is a brand, okay? There are several different things that say Sudafed on it. It does not mean that it is pseudoephedrine, okay? So you have to be very specific when you're talking to your patients. If you're wanting them to have pseudoephedrine, you can say, hey, you can go get pseudoephedrine or Sudafed. It's the one that's behind the counter. You're gonna need a license for it. They're gonna have to have some type of state-issued ID to be able to get it. If they can just walk up and grab it, that's the Sudafed that is like the phenylephrine, the not as effective one, or it'll have some other stuff in it, okay? We want them to get this is the best one that we have for nasal congestion. Phenylephrine, I tell people like, don't waste your money. When you get the phenylephrine, it's like, it didn't work. I'm like, yeah, I told you, but it was cheaper. That's why it didn't work. No, I'm just kidding. It's not as effective. It's not as effective than when we're comparing it to your pseudoephedrine. So always remember that. Always remember that they're gonna need an ID to purchase it. Looking at your adverse effects, the other thing that we like to tell our patients, because it can be activating, it can cause some patients to have that hypertension, that tachycardia. So it's not an absolute contraindication in our patients who have high blood pressure. But if it's very high and it's not controlled, we will typically try to make them stay away from this because we could put them into an unsafe range with their blood pressure. So if your patient is managed well, not something that we typically worry about, but drug companies, they did a great job marketing. So we have different things that will say like Sudafed HBP for like patients with high blood pressure, because then it doesn't have the pseudoephedrine in it, and people are buying it thinking that they're getting pseudoephedrine and they're still not getting the pseudoephedrine, okay? Then you see that we use this, and the reason why it's behind the counter now, why we have to scan the patient's license. So when they come to the pharmacy, we have to scan their license. It puts their information into a database, and once they hit a certain amount that they have purchased, we'll talk about this later, that they have purchased, it will cut them off, and they can't buy anymore. Okay, we can't sell it to them because they hit whatever their limit is. So when we talk about this, remember that this is the drug that they're using to make meth. And then, again, that false positive that you can have in your patients who are using it. So what I like to do and what I like to see whenever you have a active duty member who is coming in and they're seeing you and they're talking to you about congestion or that they have frequent congestion, you can order this, and we do have this in the pharmacy, and then they don't have to pay for it, which is another plus. And I usually just will have it on their profile if that's typically how they present whenever they have allergies or if they get sick and they can't breathe. I usually will just leave this on their profile and just kind of have it and tell them, oh, if you need it, you can go to the pharmacy and pick it up. Interactions, very similar. Make sure you have that washout period of 14 days prior to you, if they've had an MAOI. So if you're gonna have them start this, then they need a washout period or drug-free of that MAOI for at least 2 weeks before they use this medication. Bless you. Okay, looking at our antagonists, okay? So remember whenever I was telling you anything about an antagonist, you're thinking about it blocking. So now we're doing the opposite of what we were doing with our agonists. We're trying to calm things down. So when I think about my alpha, where is my alpha located? My vasculature, right? So I have a lot of, well, I can ask you this way. Does it excite or does it inhibit? Excite, right? So if I'm exciting, what can happen? Do I have vasoconstriction or do I have vasodilation? All right, now we're good, okay? So when you're looking at this, go in and just plug in your drugs. What I also, oh, you can't even see what I'm pointing at. What I also tried to do here was put the endings so that you can remember what, like how the class kind of is named, okay? So that you can see and try to say, okay, if I see Zosyn, that's my alpha 1s. If I see an alpha 1A, which is more specific, I just see Osin on those medications. So kind of look at that and then see if you can fill these out as we go through this. Beta blockers, we're going to touch on this. You're going to continue to see this. You're going to see this again next semester. We talk about this and kind of where they fall in the different types of beta blockers that we have. Okay? So when I'm looking at my phenoxybenzamine, this medication is an antagonist. So think about it as it is going to now reverse those effects of what we were typically seeing if I had alpha 1 or alpha 2 activation. I am now blocking that from occurring, okay? So I'm trying to stop the vasoconstriction, which will therefore decrease my blood pressure, okay? So now I'm doing the opposite. When we were talking this first part of this lecture, we were trying to increase these things. Now we're trying to decrease these things, okay? So clinical use, we're looking at this, pheochromocytoma. So when you talk about pheochromocytoma, that's essentially a tumor that some patients can have in their adrenal gland, and it will cause them to have excessive sweating because they are consistently secreting norepi and epi. Okay, so their body is always thinking like they're in that fight or flight mode. And so what we're trying to do is say, hey, let me try to decrease the symptoms that these patients are feeling. The real way that you're going to try to fix this is to remove the tumor, right? Because I'm just putting a Band-Aid on it with the meds. I'm just treating the symptoms. I'm not treating that actual tumor, which is our cause. Don't worry about the dosing. Just know that we're titrating that. And then our adverse effects, right? Because I said now I'm stopping that vasoconstriction that I was seeing. So I'm just essentially doing the opposite. I'm not allowing my body to vasoconstrict. So now you're going to see that orthostatic hypotension. Make sure that you're telling your patient, get up slowly, all of the things that we are worried about, especially if they're older. That's definitely a caution that we wanted to have. That reflex tachycardia, because now I've dropped everything, I've lowered everything down, my body is like, pick me back up, and then I have the reflex. Nasal congestion, nausea, and vomiting. When we typically see this, your nausea and vomiting can be from sometimes your patients, if they have that dramatic drop in their blood pressure, they just feel nauseous and lightheaded and dizzy and like just uncomfortable. When your blood pressure is low, you feel it. Just like when it's high most of the time. And just like when it's high, most of your patients will feel it. And then that nasal congestion is essentially happening sometimes because we just increased our flow because we don't have that vasoconstriction. Drug interactions, our alpha agonists, right? So they're going to oppose each other. And if I give an additional blocker, I can potentially tank my patient, right? Because now I'm having that additive effect. So I don't want to give two of these together, two of my alpha blockers together, just one in that class. We're now looking at my phentolamine. So when we use this, you'll also see this used in some of your patients who have that symptomatic pheochromocytoma as well. Non-selective, so right, anybody can get it, alpha 1, alpha 2, I'm just trying to bind somewhere. What you see here is this antagonizing your alpha constriction, right? So if I'm antagonizing that, I'm causing the relaxation. I talked to you already about my decrease in my blood pressure, but I can have improved blood circulation that can minimize necrosis if I did have that my line slip and I'm worried about tissue necrosis. Instead of how we talked about with epinephrine, where I can vasoconstrict and keep something in that area for a long time, now I want it to spread out. I want it to be diluted throughout my body versus stuck in this one area. So you'll sometimes see that we're using it to treat the extravasation of some of our medications that we have, okay? So those drugs that can potentially have extravasation occur, which will lead to that tissue necrosis. I don't want it to stay in that spot. So if I stop vasoconstriction and I vasodilate, I can have that drug now move from that one area and avoid the necrosis in your patient, okay? You see that we can use this for, I told you already about the treatment of PCC, but you can also use it to diagnose it, okay? So if you're just trying to see what's going on with your patient and if they potentially have this, they will respond, they will have a decrease in those secretions or the sweating, and that's how you can say, okay, maybe there's a tumor, there's something else going on here that I need to snoop a little bit more to find. Also, your treatment of impotence, we do not really use this for that because look at my formulation, okay? I'm not trying to have someone have an erection if they're in the hospital. I'm probably also not going to send this home with them for them to inject themselves or to put themselves on the drip, okay? So when we look at that, you're not typically ever going to see it used for that. But the idea behind it is if I am going to cause vasodilation, I can have that increased blood flow to that area, and therefore it's easier for someone to have an erection because now they have the increased blood flow. The erection is happening because there's increased blood flow. If I decrease blood flow, like we'll talk about with beta blockers, that's how you can see where sometimes people will have impotence because now they don't have enough blood flowing, okay? And then adverse effects look very similar to what we already saw. And then watching out again if you're going to use more alpha blockers because I'm just going to have that additive effect with those medications. Okay, so looking at alpha-1 blockers, right? So now this is specifically trying to be more selective now. I'm specifically looking at my alpha-1 and I'm trying to, when I use these medications, I'm going to use them for hypertension. A lot of the times when you prescribe this, you're definitely going to be using this for your BPH, and then we have PCC there again. When I look at this and I look at the mechanism, right, I'm blocking my alpha receptors, so therefore I'm having that same vasodilation that we were just talking about. I can also get some relaxation of the smooth muscle. So if I'm a person who has BPH or I'm retaining my urine, if I relax that smooth muscle, now I can have my patient be able to use the restroom. They're going to have less symptoms, better quality of life, okay? So this is the big idea behind our alpha-1 blockers. All of these are going to end in dosing, okay? Dosing, when we're looking at this, a lot of patients will say like, oh, I feel very tired. Again, especially if they see that drop in blood pressure, if they did have higher blood pressure, again, the effects that people feel these side effects in are going to vary. Some people may not feel any type of side effect at all. Just because it's listed doesn't mean that it's going to happen, okay? Because of the studies, we have to have it on here. So looking at this, I'm giving these medications to our patients at night to make sure that if they do get sleepy, they're not falling during the day, they're going to sleep anyway. Adverse effects, that orthostatic hypertension, essentially this will start to go away. It's more so exaggerated when they take that first dose, so make sure you're just giving that patient education that they're sitting down when they take the medication. They should be getting ready to go to bed whenever they're taking it. So again, make sure that they are in a safe spot, especially as they are initiating and starting this medication. The reflex tachycardia, especially in our patients who have angina, we'll talk about angina next semester, but you don't want to have any more exertion or increase that heart rate at all. What happens here is that I can have that reflex tachycardia in my patient. We already talked about the drowsiness and then the same things that we were seeing before with the nasal congestion. When you're looking at this inhibition of ejaculation, this is not something that is very, very common. You will see it less with your alfluzocin, which we're going to talk about. That's one of the alpha-1 blockers that we have. The person will still have an orgasm, so they can let them know that. The issue is that they may not see the ejaculate actually come out. So again, a conversation with your patient, because that is something that is abnormal to them. They will think that something is wrong, because if I typically have this happen and now it doesn't when you put me on a medication, you should alert me so that I don't just stop taking my med, okay? Because that's what will happen. Looking at your contraindications, we talked about hepatic issues, right, and our Child-Pugh score. So someone who has a B or C, they're more moderate to severe. So you see that we are making sure that we are looking that up because it is contraindicated in our patients who have a B or a C Child-Pugh score. So hepatic metabolism, we're worried about. Looking at your interactions, you see that we are not going to use it with our SIPs. I don't need you to remember the SIP. So look at the fact that it is if you have a SIP inhibitor, I should not be using my alfluzocin with it. And we'll talk about our antifungals. That's what azoles are. Antifungal medications, if somebody is on one of those for a long period of time, which typically they are to treat a fungus, it takes a long time to kill it, you'll see that we shouldn't be putting them on an alpha-1 blocker. And then avoid use in our patients who would be potentially taking an alpha-1A blocker, which is more selective, and we're going to talk about those in a little bit. Just you'll have that additive effect, which we'll still be worried about. And then caution with our patients who are using PDE5 inhibitors. So again, that's if you're asking one of your patients like, hey, are you taking Viagra, Cialis? Again, ask them the names so that they can say yes or no. What we're worried about there is having that orthostatic hypotension, okay? So the additive effect, we're worried about the side effect, the hypotension, that drop, which could take them out. Here are all of your alpha-1 blockers, okay? Prazosin, doxazocin, terazosin, alfluzocin. What I want you to pay attention to is our comments that are listed here. When you look at prazosin, a way for you to remember that you can prescribe this for your patients who have PTSD is that it starts with a P2, right? So prazosin, I can use this for PTSD. You'll also see it used for your patients who have nightmares. And think about patients who have PTSD. A lot of times they're going to have those nightmares, so kind of help you lump that in together. Make sure that you're also paying attention to when you can use something for hypertension versus when you're using something for BPH, two different indications, okay? So my prazosin I'm not using for BPH. I can use it for my nightmares. I can use it for my PTSD. I can get some relief to drop that blood pressure as well. When I'm looking at my doxazocin, you see that your IR and your XL, you can use it for hypertension and BPH. I don't like how this is worded, but when you're looking at the use of them, just make sure that you're understanding that this is also your drug of choice for your PCC. Okay? I have to reword that, so I'm not even going to ask you a question about that one. I want you to know that it's the drug of choice for your PCC. Your terazosin, most of the time when you're using this and when we see it, we use it more for our blood pressure. So more for hypertension than, I said that so backwards, more for BPH than hypertension. So terazosin, you can use it for both, but typically when you're going to prescribe it, it's going to be for your BPH patients. Same thing with your alfluzocin, and this one is only approved for your BPH patients. This is a very good medication, and it's very selective, so that's why you see selective for alpha-1A receptors in the lower urinary tract. So there are less side effects that you'll have, less side effects that you're going to have when you're looking at the selectivity for having that alpha-1. Okay, so prazosin, dealing with things with our PTSD and our nightmares. Looking at your doxazocin, I want you to remember PCC. Looking at your terazosin, I can use this for BPH or hypertension, but most of the time when I'm using my terazosin, where you're using it for BPH. And then your alpha-zocin is specifically for your BPH patients. Also, I wanted you to remember with the dose, the only thing is, am I taking this during the day or at night? Typically, I'm taking these at night, okay? So that's all I need you to remember for the dose, so you can just block out that whole middle, those middle two columns. You'll use it probably later, but for your reference later. Okay, so now I'm getting more uro-selective. We have our alpha-1A, which now you've dropped the Z. I'm more specific so that you can remember the ending in this one. There's no zocin, it's just ocin. So when I'm looking at this, same mechanism with that relaxation of the smooth muscle. And then when we're using this, we're talking about our patients who have BPH and they have it's enlarged. So they're gonna see a lot of incontinence, they're gonna have a lot of symptoms that are gonna essentially make it uncomfortable for them to go to the restroom. When we look at our monitoring for this, make sure that you're seeing, have their symptoms improved? Because if their symptoms haven't improved, then there was no point in giving them the med in the first place, right? So I'm monitoring their symptoms as we should with any medication that we give. But you're also going to look at their prostate symptom score and their urinary retention. Okay, so you're trying to ask them hey, are you having, again, that's a big symptom of our patients who have BPH is that they'll have a lot of retention. So asking them about this, how are you doing? How is everything going? You're specifically targeting the bladder when we're looking at our alpha-1A, okay? Adverse effects, the things that we already saw. What was different here is that you see that you have IFIS. And when we're looking at IFIS, this is essentially there's an issue with their eye and they're not able to contract those iris muscles. So they're essentially just very laxed. You'll see this more in our tamsulosin, which we'll talk about our drugs, but you'll see your IFIS occur more in your tamsulosin. We're talking about the abnormal ejaculation. So they can either have retrograde where it doesn't come out, it goes back into their body, or they'll see it looks like it's less than what it normally is. Again, educate your patient, let them know that it's just a side effect of the medication. When we're looking at our ejaculation issues, you have less when we're talking about our silodosin, which we're gonna see on the next slide. That's another one of our drugs. And then the nasal congestion, all of those things that we already saw with our other meds, more so I'm gonna see those with our tamsulosin, but nothing new there. So your big thing that is new here is that we're worried about that IFIS that can happen in our patients. Contraindications, looking at hepatic and renal issues, okay? And then our interactions, same thing that we already saw, our PDE5 inhibitors are what we're gonna be worried about. So, when you're looking here, all of the little tidbits that I was saying on the other side are right here in this chart. So you have your tamsulosin and your silodosin. Most of the time, they're going to prescribe tamsulosin. This is the more popular of the two. Don't worry about this dosing, but what you see here is that I have all of those comments, right? So if I'm looking at my tamsulosin, I have more abnormal ejaculation with those patients. Priapism could occur. Depending on how long that lasts, you may have to use a needle to get some of that blood out of the penis if it doesn't go down and you can't get the erection to go down. You will have to remove it for them. Looking at your blood pressure, you see that this has the least amount of effect on our blood pressure. We have more of the congestion that we saw, and we have more of a possibility of IFIS. Now, I told you that this is a very popular medication. A lot of these side effects, we don't see it a lot. People tolerate this medication very well. It's just the side effects sound horrible. It's like the commercials that we see. And then looking at your silodosin, contraindicated, make sure you remember contraindicated in your patients who have that severe renal or hepatic issues. So think about it this is more, your silodosin is more selective for if your organs are working correctly, okay? When we talk about this IFIS, they try to say that if a person is going to have a procedure that they need to have specifically on the eye, which would be something like cataract surgery, things like that, then we need to have a washout period, okay? So we would try to take them off of this medication because we're gonna go and work on the area that could potentially be affected, right? So we will try to do that 2-week washout period to say, hey, I want a clean slate whenever I'm operating on my patient to prevent them from potentially having the IVIS occur, that syndrome occur. All right, looking at our beta blockers. Beta blockers are something that you are going to continue to see. These are very, very popular medications, several indications that you can use them for. You are going to prescribe these, okay? So make sure that you keep these in your memory because you're going to see them again and it's gonna help you a lot if you remember them now for when you take your PHARM 2 exam or an exam, okay? So when we look at our mechanism, beta 1, beta 2, it's gonna block that receptor. And so when we talked about our beta 1, does it excite or does it inhibit? Excite. So now I'm inhibiting that. Remember with our beta 2, we had inhibition, but we also had some excitation when we were talking about the pancreas with the glucagon and all that good stuff. So now we're opening stuff up instead of closing things like we were typically doing with our beta. Looking at your different decreases, those are all the things that are now gonna drop, right? I'm gonna drop my heart rate, I'm gonna drop my blood pressure. Again, very good medications, very common medications, because these are things that, as our population is, we have a lot of these issues. So this is why this is one of those top drug classes that you're gonna see used in several different disease states. You see with that angina that it helps your patients try to meet that demand, because if I can slow down my heart, I can catch up to that O2 demand that my heart is telling me and my body is telling me that it needs. So I use this drug and I say, okay, I'm gonna slow everything down by giving them this beta blocker. Looking at your beta 2 antagonism, you see that it is inhibiting all of these things that are listed. So it's inhibiting the dilation, it's inhibiting the relaxation, it's inhibiting those things that we were talking about with the glucose, okay? So now just think about it as we're doing the opposite of what we were doing with our agonists, okay? Decreases that aqueous humor production, okay, so that's good for our patients who have glaucoma. Specifically, we'll have the one that is in an eye drop formulation, which is gonna be your timolol. Okay, so we'll look at these and we're gonna go through them and remember the different types of beta blockers. So, clinical uses. This is an extensive list, right? Because there's so many different things. This drug is very versatile, so that's why it's one of the ones that you'll see several different times. So hypertension, angina, heart failure, arrhythmias that you have, especially if they're going fast, right? Because I'm gonna slow things down with my beta blocker. My MI, because again, those patients are gonna be in pain. They could potentially have tachycardia depending on what's going on and how they present, glaucoma, thyroid, my PCC is there again. These were the medications that we were talking about where we were like, we're gonna taper off, we're not just gonna abruptly stop, right? Because we have that unopposed action that's gonna be happening. So, same beta blockers, we're just gonna go into more detail about them. Adverse effects listed here. Big things that you're gonna be worried about is hypotension, bradycardia, especially if you're giving it with another medication that's gonna slow down my heart rate, right? Now I'm worried because I have additive effects. The metabolic disturbances, because remember, I'm now messing with what's gonna happen with my glucose and my fat. I'm altering all of those things. So that's why when we talked about those receptors in the beginning, if you realize I'm dealing with an agonist or a blocker, you can kind of realize what your indications are gonna be, as well as what your side effects are gonna be, okay? Because of the eye drop, that's why you see the burning and the stinging. Remember I told you that's like a common thing that a lot of people are gonna say whenever they're putting any type of drop in their eye. Make sure that, another basic rule with any type of eye drop, that they don't use the tip of their dropper and like stick it onto their eye, right? Because if now, especially if it's a multi-use vial, now I have whatever bacteria that are in my eye now sitting on the top of that lid, and they're gonna make their way into somehow my eye again. And it can potentially cause an infection and so on, and then now they have another issue instead of just their glaucoma. Now they have an infection, okay? So make sure that you're telling your patients to, when they put their drop in, to not let that tip of their dropper touch their eye. And then a big one that you need to let your patients know about is going to be your erectile dysfunction and depression, because those are two big things that can happen. So we call it beta blocker blues, and essentially what some people will say is like, because we kind of decrease the activity, is that they kind of just feel down. They're not having a lot of that outflow anymore. And so if you have a patient who has a history of depression, you're more likely to see that occur in those patients, okay? Looking at our interactions, if I give it with an agonist, if I give it with another beta blocker, if I give it with a non-DHP calcium channel blocker, because when I look at my non-DHP calcium channel blockers, those also are working on my heart, and they're gonna slow it down also. So if I'm giving that, in addition to a beta blocker, I am now greatly decreasing my patient's heart rate and making them have bradycardia. Contraindications, if your patient is already bradycardic, I don't need you to remember lab values, so if something is low, I'm gonna say it's low. If you see low next to a heart rate, that means they have bradycardia. It's not where it should be, okay? So you don't need to remember the numbers. When we talk about heart block, I don't need you to remember the degree of heart block. You're gonna get that somewhere else. I just want you to remember that they're not great in heart block. I'm not gonna trick you and say, oh, did you remember what, if it was second degree or third degree? So I would just be like, if the patient had heart block, I'm just gonna say they had heart block, and you should be like, oh, they probably shouldn't be using that, right? They shouldn't be using the beta blocker. For your patients who have decompensated heart failure or asthma, again, with these patients, looking at your patient who has decompensated heart failure, what we're worried about there is that they're probably gonna have a lot of fluid on them, their heart is already gonna be struggling to work, so I need all the pump I can get out of that person, because their heart is already failing, they have heart failure, okay? So if I slow things down, I'm going to probably decrease my perfusion quite a bit, and that patient is not gonna feel great. I'm gonna worsen their heart failure that they have, okay? And then your asthma, you can see where some of your patients will, because of that adverse effect of the bronchoconstriction, you're now going to worsen that patient's asthma. They may have an increase in the amount of exacerbations that they have. Okay. Y'all, does this look familiar at all? Have y'all seen this anywhere before? No, not yet. Okay. So when we're looking at our non-selective, selective, mixed, and non-specific, and our ISA beta blockers, these are all of the different types of beta blockers that we have, okay? When you look at your non-selective, typically your non-selective are gonna be O through Z. They typically start, we'll say N through Z, okay? When you look at your selective, those are usually A through M. This is a way for you to try to cheat to remember them, okay? So those are your medications that you have, and then I put your Timolol, and just remember that that one is the one that's your eye drop formulation that we use for our patients who have glaucoma. Now, to remember your mixed and your non-specific, I say I mixed up the paint for my car in a lab, okay? So carvedilol, labetalol are your two mixed or non-specific beta blockers that you have. And then your ISA or your intrinsic sympathomimetic beta blockers that you have are going to be your acebutolol, pendolol, and penbutolol. So ACE-PEN. Doesn't matter how you're spelling PEN. P-I-N-P-E-N, ACE-PEN are your ISAs. Okay? All right. Looking at our mixed, you have your carvedilol and your labetalol. So I'm mixing my paint right in the lab, because I'm mixed action, my lab for my labetalol, and my car is carvedilol. So looking at these, alpha blocker, non-selective beta. So I'm targeting my alpha, but I'm also hitting my beta receptor, okay? And I don't care which beta receptors, I'm hitting my beta receptors. So when you look at the use of these, we are going to use them in hypertension, and you can also see them in congestive heart failure. So that's what your CHF stands for, and HTN is hypertension. Sorry. So whenever I'm looking at hypertension, I'm going to decrease their blood pressure, is essentially what this is saying. So decreases the rate and the strength of the contraction of the heart without reflex vasoconstriction. So because I don't have that vasoconstriction now, because remember, I am an alpha blocker, I'm stopping that from happening, I can now just work on decreasing that, my blood pressure. When you're looking at CHF, you are again decreasing their heart rate, okay? I'm decreasing their heart rate, but I'm not allowing that vasoconstriction to happen. Because I still have my alpha action that's there. I'm blocking it. Okay? So just understand I can use it in hypertension, I can use it in my patient with congestive heart failure. Looking at your clinical use, hypertension, congestive heart failure, if you have somebody who has severe hypertension, we'll talk about this next semester, but you have like your hypertensive urgencies and emergencies, and when we have like an emergency, we're trying to like get their blood pressure down safely, but you typically will use an IV medication instead of using an oral medication to get them down. And then looking at our dosing, because of it dropping down that blood pressure, what you will see sometimes, again, is that orthostatic hypertension that we talked about. With these, you can take them with food to decrease that, or you can try to have your patient take it at bedtime, but most of the time, people are usually having blood pressure issues during the day, so I like for them to take it in the morning and just have it with their breakfast, okay? If they still can't tolerate it, then you can switch it tonight. The medication is still gonna be working. It's just that if their blood pressure just so happens to drop when they lay down at nighttime, now I could potentially be dropping them too low, because there's no activity going on for them. So just watch out for that. Adverse effects. Again, those same things that we talked to you already about with our asthma and our diabetic patients. With my diabetic patients, I can mask that hypoglycemia for them. This is what we talked about in the very beginning. And then that orthostatic hypertension, the potential of that bradycardia happening and then being worsened if we add on any other medication, that also decreases that. So our contraindications are the same that we already saw, right? So asthma, the heart block, remember I want you to remember the degree specifically for this. And then your bradycardic patients, if they're very, very low. So if I'm giving you something that's less than 60, I'm still worried about them. That's not how it says severe bradycardia. Like you're looking severely, they're in their like 30s, 40s, like they're super low, right? Because we want to be at least 60. And 60 is on the lower end of our normal range. So if I'm looking at that, if the patient is easily symptomatic, they don't need to be severely low. That 60 can be low enough for that patient to where when you put them on that beta blocker, it can drop them just enough to where now they're starting to feel that lightheadedness and everything. So check in with your patient to see how they feel after they started taking it. Are they complaining of dizziness? Are they saying that they're sleepy? All of those things will then help you with your dosing. Interactions, these are the same ones that we had already talked about, right? So because I have mixed action with my alpha and my beta, I need to watch out for anything that is going to stimulate or try to stimulate my alpha and my beta. My additive effect, if I add on something else that falls into either one of those drug classes, an alpha blocker or a beta blocker, because I already have alpha and beta blockage with these medications. So if I add on any one of those as an individual pill, I've now compounded my potential to have any of those side effects occur. Bless you. And then the cumulative with your non-DHP, again, our non-DHP calcium channel blockers also work on the heart and slowing it down. So that's where you're seeing that additive effect to where you could have bradycardia, like you're going to tank your patient. All right. So when we're looking at our meds, these knowledge checks are a little bit different than what we had in the first one, right? Because now we have some more drugs trying to jog your memory to look at what you're going to see. What does it look like for the exam? I can just ask you a question like this. I want to know the indication. I want to know the adverse effect. I want to know how it works. I want to know what other drugs I need to avoid. Oh, and if I did give that calcium channel blocker with my beta blocker, what's happening? What am I expecting to see, right? So that's kind of what this will look like. I'm going to make sure that this weekend also that I'll post like some little quizzes. I'll make sure that those quizzes that are up right now are my most up-to-date ones. And so I will edit that so that you can see that as well, okay? And I will put them under the lecture that they belong with, the quiz, so that you can see that I've already verified that this is our most up-to-date one, okay? So I'm going to rearrange it. So what's my indication for my dextroamphetamine? Good job. Keep me up, right? Stimulate everything. What was my main neurotransmitter that we've been talking about? Norepi, I keep displacing it, I'm worried about norepi. What are my receptors that I'm looking at? What were we just talking about? What kind of blockers were we looking at? Alpha, we were looking at beta receptors. Okay, so remember where my drugs are working with these systems versus my sympathetic versus parasympathetic, because they're different, okay? What happens if you give a beta agonist with a beta blocker? What if I gave a beta blocker with a non-DHP calcium channel blocker? Right? Additive effect, both of them are gonna cause bradycardia. What are the effects of an alpha-1 receptor exciting, inhibiting? What am I doing? My alpha-2 is doing what? Inhibiting. And where are my alphas typically located? Well, yeah, vasculature. Not gonna ask like pre or post snap, but vasculature. My beta-1, where is that typically located? Heart, one heart. Beta-1, one heart. And my beta-2? Okay. Our beta-1 receptor, remember we talked about this, right? Excitatory, and both of your 1s are excitatory. Your 2s are inhibitory minus the effects that you're getting in your beta activity, and we're talking about the pancreas and what's happening with the pancreas, okay? That has an excitatory portion to it, but everything else for your beta-2 is also inhibiting things, okay? What drug is an adrenergic agonist that we use for our anaphylactic shock? What's a big thing with this is, do I get the same effect with all of my doses of epi? It's gonna vary, right? Depending on how I'm hitting my receptors, my selectivity will change. So these are the kind of things that we're gonna look at, and like just when you're studying, y'all did very well, okay? Go through it and just, I went over that the very beginning. Are we having direct questions about it? No, when we're talking about those receptors, like I'm not gonna like, hey, what is the alpha-1 receptor doing? But if you know that when you're studying, it makes it a lot easier for you to remember. At that point, you can remember your mechanisms and be like, I know what's gonna happen. I know what I'm using this for, right? Because I know the effects that I'm getting when I hit that or when I block that receptor. If I hit the receptor, if I turn it on, I am an agonist. If I block it, I am an antagonist, and I'm gonna get the opposite of what I expected to see, okay? Agonist on, antagonist is off. Let's take our break, come back at 11, and we will do our anesthetic. Let me check.
Oh no, well that's different. It's like it's just I'm good. Like how I do it with drugs. I gotta remember like same drug. Remain just practicing their mechanism. so I'm kind of that's what I did. That's what I'm gonna do. And also, like, I just know where they oh, it's this drug, it's this part of the slide. Thanks, dude. I knew I was yeah, what's TG, guys? Yeah, discipline, dude. How'd you get it late? Run by San Tom.
But you'll inject it. Use the neural. Use the neural.
It's great. It's still a very
Yes, it's not a blood issue, it's a nerve issue. They're going to force an erection that gets Exactly. Most people do things. I see some products use that shit like a diagnostic tool. Like, oh yeah, you claim? Let's see. Yeah. Hey man, I was speaking to someone.
Make sure they find it and then they're going to and when they for that
48 questions, right? I fixed the blood issue. I'm like, okay, I remember. They come back like, hey, we need to take blood twice now.
if you're able to get somebody
There, but I'm not where I was. My last unit, I mostly
I don't know what this is. I have to look up that takes actually
versus 5 is like 30 and sorry, big. It's not.
what is
drugs are bad. Everyone says drugs are bad, but here I am. Maybe you want power for 50 I probably think an hour more than an hour.
I think we can. The thing is, it's about and this will really go down like this is what Ethan does, like the it has 10 feet by itself and it's from we'll do not shoot the ID but the rest of it is like it's very light. Here's the like group together and they all
Have you heard of the nurse? I mean, I just hear the nurses. That's hard. So that are they sure to be there? But you know what surprises me when we do get when you look at the stuff, yeah, but imagine
that's a better question. I don't know if it might be more like if you go into that field and you work in that field, it's like you're program.
salary.
It makes sense in the sense of like,
Of how the actual income is.
but like when you work in surgery, it's more of like you're not right? PA doesn't do the first one. That's why what monitors I know
I really think you guys are my
yeah, they do. But they also
What she was saying
No, I worked in insurance, so we had a lot of those guys. I always thought it was a bridge. I know how to do it. What am I doing?
definitely
Actually,
like going over. And they would always be
well, my girl. She was there.
Alright, our anesthetic beds. What did I tell y'all I was gonna post? I had to post That was real smooth, I like that. Not gonna work, but that was smooth. It was something with was it a slide or something like that? Thank you, I have to write stuff down, I'm getting old. Bless you. Coordinated stuff. Okay, so anesthetic agents. Some of these we're gonna, it's gonna be like a little review. Some of them I'm gonna lightly touch on them because we're gonna go over them in another block in more detail. And I just need you to kind of remember where they go, okay? All right, ELOs listed here in our little what do you know. We're not gonna do this one because we are gonna kind of go through this a little bit quicker, so I hid those so that we don't have to worry about it. When you're looking at your anesthetic medications, what I want you to understand about this is that you're trying to help your patient through whatever the procedure is that they're going to go through, right? You have different options and different like reach depending on how you're going to give it. So if I give a local anesthetic, it's going to stay in that spot that I give that I administer it at. Versus if I give a general anesthetic, it's going to generally spread everywhere. And then I have different things that essentially prep my patient for my procedure. So when you're looking at your pre-anesthetic medications, these are several different things that you can give to your patient prior to you doing the procedure. Sometimes if you know that if it's a scheduled procedure, you can order these ahead of time, have them go and pick up these meds prior to them having the surgery, versus them trying to have somebody scramble while they're in surgery to get these meds, and then you're holding, or not even in surgery, you're holding them to try to get some of these meds. A lot of these medications you will give right before you're doing a procedure, So pre-anesthetic medications are pretty good with us trying to like minimize some of the effects that we may see because we are giving our patients anesthesia. Looking at our general anesthetics, different routes that we can give it, okay? So you see your inhaled versus your IV. And then you have your NMDAs, which we talked about, right? So our neuromuscular blockers, we're gonna go over that again. And then your local anesthetics, which are the ones that are staying where I put them. Wherever I put them, they're typically staying in that spot, so I'm not having as much or as a, I'm blocking what they're feeling in that one spot versus like the general anesthesia when you see all the videos and everybody comes out and they're all loopy, okay? So that's the big difference between your general versus your local. So we're gonna start with our pre-anesthetic medications. When you look at these meds, essentially I am prepping you for the procedure that I'm about to do. If you are nervous, I have a medication for that. If you are already in pain and I want you to kind of relax prior to me doing the procedure, I have a medication for that. If you're very sensitive to anesthesia and you vomit a lot after the procedure wears off, if you're itchy a lot after your anesthesia wears off, I can pre-medicate a patient and help them. So I have my antacids, which are going to help with that gastric acid secretion, hopefully help me not feel as nauseous or if I make me feel like I have to vomit. My anticholinergics, again, those are going to help dry things up, right? My anticholinergic. And I have those to help me prevent nausea and vomiting. I also have my antiemetics that are going to, again, help me with that vomiting. Your antihistamines, benzos. Your benzos are good to help with that anxiety. Still lots of effects that can kind of come along with it, but our benzos, we can still use those because it's not like we're giving them a dose for them to take home. We're just giving it to them while they're getting that procedure. And then our opioids are very good medications that help with pain. A lot of the times we will also send our patient home with an opioid depending on what type of procedure they had. Again, making sure that you understand a lot of our opioids are typically going to be our Schedule II medications, so you're giving them just enough medication to get through whatever you think that recovery period is, or to get them to that follow-up so you can reassess and say, all right, how much pain are you in? Because maybe you think that they should be better in a week, but it takes them 2 or 3 weeks to recover. They're still in a lot of pain. You may have them come back in and they're telling you that their pain is now increased and you need to go back in to do another procedure. You never know, so make sure that when you have that prescription that you write for them to take those opioids home, if you choose to give them an opioid to take home, that it's just enough to get them back to that follow-up appointment. You give them enough, they might not come back to their appointment. Oh, I'm good. Gave me 30 days. Don't need to go back. So make sure that you give these. They're important. We are going to touch on them, bless you, in more detail. I had my C-section, and after the second one, I was like, oh, I vomited, and I didn't like how that felt because they had just cut me open, and I was vomiting. So when your stomach is cut open, vomiting does not feel great. So on the last one, I was like, can you give me meds beforehand to make sure that I don't vomit, and I wanted a scopolamine patch. And so they forgot to order the scopolamine patch, so I was like, okay, well, can I have meds before we do the anesthesia? And I thought that I had taken it, but I was like so all wrapped up in the fact that like I'm about to have another baby. They forgot to give me my meds, all of them. They didn't give me everything. I was just taking, stuff as they were bringing in my pre-anesthesia meds. And I got in there and I said, I feel sick. Did you give me my meds for my nausea and vomiting? I said, I need a bag. I need a bag. And he's like, are you sure? They like to ask, are you sure for some reason? Which makes me upset. Okay, are you sure? Yes, I'm sure. By the time they get the bag, I'm like, ugh. And I was like, please make sure you change my gown. My husband came in, he's like, what's that green stuff? And I was like, just let them do this. Like, I don't have time for this right now. So I hear the attending asking the resident, hey, did you give her meds? He's like, I think I forgot, but can we just document that I did? Don't do that. And I was in a position to not argue with anybody because clearly I am drugged up and my legs don't work. And I also don't want them to kill me. Hopefully they wouldn't have done that. But make sure that you understand the importance of this, right? Because now I remember that very vividly and clearly. And I'm a pharmacist, so your job is to make sure, like, hey, did we give this person everything that they were supposed to make sure that they're comfortable throughout this procedure, all right? I'm not gonna tell you. Had 3 kids, there's 3 different, they were not born in the same places. Induction, maintenance, and emergence, okay? These are the different stages that we have whenever we're doing anesthesia. Induction is essentially you trying to knock them out, right? You're trying to get them, when they tell you to count to 100 and you're like, yes, I can do it, and you get to like 4. Or they'll tell you to count backwards and you're at 98. That's that induction part. Your maintenance is me keeping you like that, right, throughout whatever my procedure is. So that's like when I told y'all when they were doing my C-section, granted they're not inducing us in that way, they'll check to see if you can feel things, but they didn't maintain me very well because as they were doing the C-section, I could start to feel it, right? So that is one of those things where the local anesthesia wasn't enough to maintain that feeling that that person had. And then your emergence is, if it's general anesthesia, you waking up after the procedure, or if it's local, you'll start to feel that pain, okay? It'll start to wear off, and then they'll feel pain wherever you did that procedure, their local anesthesia starts to wear off. Looking at this, making sure that you're understanding that you are trying to decrease their CNS depression at that time, right? So you want them to be unconscious if it's general. You don't want them to feel any pain. You don't want them to have any memory of what you're doing to them, because that can give them post-traumatic stress, right, from whatever the procedure is. You hear about people waking up all the time during operations where they're completely out and they wake up and like somebody is operating on their heart, okay? Imagine seeing that. Or somebody has cut something and you can actually see that they cut whatever it is, okay? So that is, we're finding that balance to drop them, to get them out enough, knock them out enough, but you don't wanna go too low, because if you over anesthetize somebody, you could kill them, right? Because I've now depressed their CNS too much. And then making sure that it's balanced, okay? Am I covering all of my bases? Do I have my patient not moving? Do I have they're unconscious? Am I helping with their pain? Like, am I hitting every realm of what this patient needs while I'm doing this procedure? And then the 5 benefits are essentially like, you're making your patient comfortable, you are also making it an ideal environment for you to operate on that patient, right? They're not working against you, they're not fighting against you because you're cutting on them and they're awake. It's just a relaxed environment for everybody is essentially what your benefits are of the anesthesia. Again, we just talked about this already, but our induction, our maintenance, and our recovery or our emergence are the things that I just described to you with that picture. I like to remember the picture because if you put words to that picture, that's essentially what we're talking about, okay? Those are our stages that we're putting our patient through. This is just telling you that as you increase that dose, you are increasing the chances of you potentially depressing the CNS to an unrecoverable state. So as your dose increases, okay, so this is your dose increasing, this is your level of CNS depression going up, okay? I don't really want to be over here, unless for some reason you're inducing me and you're putting me in a coma for a reason. There are times where we induce people and we put them in comas, but I don't want to be here ever, okay? So these are those surgeries that you see where like a patient ends up dying. Most of the time, it's typically, not most, it can be because they had anesthesia and something went wrong, okay? Whether they reacted to it wrong and they were giving it in the correct way, but their body just didn't handle it well, or it could have been a mistake, okay? You have both of those things kind of happening. All right, my inhaled general anesthesia agents. So essentially these are like the gases that we have to kind of help us do a procedure. And when you look at like those dental videos of your patients, right? You put the gas on them and they like start saying crazy things, but you can do your procedure. They're kind of calm, okay? When they emerge is kind of when you start to hear all of those things. So you have your desflurane, your halothane, your isoflurane, nitric oxide, and your sevoflurane. When we're looking at this, just know that like our mechanism isn't very well understood, but it's working on those neuron channels and trying to essentially block the neurotransmission pathways, okay? What you end up seeing and what we're gonna look at in more detail is the rate at which you see that this curve approaching 1 is the speed of induction, okay? So the quicker that I approach 1, I am going to work faster. When we're talking about our emergence is occurring with our drugs that have a lower blood gas partition coefficient. So when we're looking at emergence, if we were looking over here at our partition coefficient, let me see if I can zoom in without it going crazy. If we look over here, now my thing is on. I don't think it's gonna let me. So if we look over here, we would pick our one that has the lowest, okay? Whatever my lowest is, my lowest coefficient, that's where I'm expecting to see a quicker emergence, okay? So that means emergence is, am I going to sleep or am I waking up quickly? What is emergence?
Waking up.
Waking up, right? So that's where you're gonna see that happen. Hold on, y'all, this is like messing up.
Can you repeat that?
What happened? Sorry, hold on. It did not like that. It's thinking, give me a second. Where are we? Right here. Alright. Okay. Okay, so when you're looking at this, and we're looking at this chart, which one do I have, that acts the quickest as far as induction is occurring? Nitrous oxide, right? This is my highest one that's approaching 1. It's getting there quicker, so therefore I have my nitrous oxide, whereas my halothane is the one that's gonna be the slowest induction speed, okay? So all I need you to remember from here is this of how fast does it take for me to get there? That's me looking at my induction, my FA compared to my FI. So that's what you see over here is your FA versus your FI, okay? And then whenever I'm looking at my emergence, I'm looking at my blood gas partition coefficient, okay? The lower the number in this situation, the quicker that I am gonna wake up, all right? Okay. When I'm looking at my indication, making sure that you're understanding that this is usually for me to maintain. I also have sometimes where you can have an inhaled anesthetic to induce somebody, so to speak. Sometimes I will tell like the dentist, hey, if you're about to do something crazy, give me some of that gas first, okay? Help me like relax so that I can, like when you're doing your injection that I'm not moving, okay? So what I want you to remember for the exam is that you can see it for induction, but you'll also see this where they'll keep that gas running the entire time that they're doing that procedure. Because as we saw, we have that quick induction, but if I take it off, it's also going to wear off very quickly as well, okay? Because it's a gas. So think about it that way. I can induce with it quickly, but I can also maintain my patient with it. Most of the time, you're going to have something else to also help because this is affecting like me being able to kind of be out of it, but I could still potentially feel things. So that's why you'll see that we're giving it with some type of analgesic, or if I'm worried about you kind of like tightening up on me, I can give you a muscle relaxant. I usually see pain meds over muscle relaxants being given with this, and then you have your anti-muscarinic or your anticholinergics that can also be given with these medications. looking at our options that we have, nitrous oxide or your laughing gas, and then all of your halogenated ones are listed here. Typically, you'll see us or the dentist using that laughing gas. And then we talked about our LD50, ED50, remembering that the larger the number, the safer that drug is. You have a larger therapeutic window, so if it's smaller, then I have less room to play with, right? So this is small, this is low, so therefore these are more dangerous meds for me to be messing with, right? And getting kicked out of that therapeutic window. If this were a larger number, then I have more wiggle room, okay? Here are our different side effects that we're seeing whenever we're looking at these inhaled anesthetic agents. The longer that they're on these meds, the longer you're running them for maintenance, the more likely you are to see some of these side effects occur, okay? So that's why we're usually trying to get in real quick, get out. So your nephrotoxicity, you're gonna see this more so with your sevoflurane. Your vitamin B12 deficiency, that's due to prolonged exposure to the nitrous oxide or the laughing gas. And so it can cause anemia because there's no leukocyte or erythrocyte production that's occurring. So that's how you see that anemia happen with that B12 deficiency. Your malignant hypothermia. So when you look at malignant hypothermia, this is essentially large levels of calcium that ends up getting released, and then you have oxidative metabolism that occurs, and therefore you're not allowed. You can't supply enough oxygen, so you're not going to meet your O2 demand. And then when you remove that CO2 or you try to regulate their body temperature, you lose that ability. It can ultimately then lead to death if we don't catch it and we don't treat it, okay? So the reversal agent, if you think that one of your patients is experiencing that malignant hypothermia, will be for you to administer the dantrolene, okay? So this will stop that calcium release that started the whole issue. So reversal agent for the malignant hypothermia is going to be your dantrolene. Looking at our general anesthetic agents that we have, okay, these are going to be our ones that we're giving IV. They're going to go throughout that patient's body. Lots of effects, very rapid medications that work very well. Some of these you'll see that they'll help with several different things. So, and we will use them in combination. So we have ketamine, propofol, and your barbiturates. And essentially I'm knocking somebody out with these. When you look at your barbiturates, most of the time you're not going to see these used as much as we used to anymore because of the addictive potential. But because you're in a controlled environment, you're doing this when you're performing a procedure, it's typically okay for us to use them. Then you have your benzos, which are going to help decrease the anxiety that somebody has. When people take benzos, they also will tell you sometimes, especially if they're not used to them, that they feel drowsy, or they may start to kind of forget things. So we're using these for those properties whenever we're trying to sedate some of our patients. So if you look at these, they have that PHARM typically on the end, and then you have your midazolam. Very good medications. You're going to use those for several things. We're going to go over those meds in a later block. Our NMDAs, we already talked about these. So those are our ones that are going to stop them from moving. And you see that they're in conjunction with these other meds that are doing other things, right? Because I'm not helping them with any pain. I'm not helping them with any of that consciousness. They just can't move. And then our opioids are going to help me with my pain, okay? These are our pain medications that we're going to use to try to like negate how much they're feeling during the procedure, but also after, okay? So that's why we gave them that IV when we were doing the general anesthesia, and then we'll give them oral whenever they're going home. So, looking at our ketamine, when we think about our ketamine, just understand that you're looking at the blockade of NMDA. Remember NMDA as a part of your mechanism when you're looking at this. Also, think about this as being activating, okay? So I'm increasing that sympathetic outflow. Remember when we talked about our sympathetic outflow? That was like our fight or flight, right? It's time to go. So stimulating that central sympathetic outflow, and then I'm going to see now everything goes up, okay? So when we see that sympathetic outflow go up, fight or flight mode. So all the things that we talked about when we were looking at the sympathetic nervous system, those are things that you could potentially see here. Short-acting medication, which is why we like it, because it's a quick on, quick off. If you deploy and you're looking at pain meds and different meds that you're gonna use this a lot. Like, you're definitely gonna have this for you to treat your patients on the battlefield. Now, this dissociated state is what we worry about, especially in a deployment setting. So, I may not feel pain, and you see that it says with or without consciousness. So this state, depending on how they are and how that person is, or what the last thing is that they remember, you can kind of see that they can become sometimes like violent whenever they emerge from being on ketamine sometimes. So we're being very careful whenever we're using this medication. If you do have to use ketamine on somebody, take their weapon away from them, okay? Don't let them have their weapon, because you might be the enemy whenever they wake up. And we don't need those problems, okay? Looking at our benefits from it, we can see where they do have amnesia, right? Which is a good thing, depending on what happens. So hopefully they do end up getting this side effect whenever it comes down to, like, depending on what the condition is. But typically when we have somebody who's doing or undergoing a surgery, we don't want them to remember what we did to them. We just want them to wake up and yes, they might be in pain, but we fixed whatever the problem was, yes.
Now, could you explain how you get a sedative state when they have an increased blood pressure and heart rate and everything?
So when you're looking at NMDA is kind of one of those weird receptors. And so it's kind of like the side effect, so to speak, of the drug that causes them to end up being sedated. You're still gonna use other meds. You're still gonna probably add on like a benzo or something for them to kind of like further sedate them. But we are using this a lot of times to get some sedation plus the pain relief that you can see in the ketamine. It's a very versatile med, but it's like a lot of intricacies to the drug, but we love this drug. So we can talk about it a little bit more offline if you want to look at it. But that is definitely one of the things, that amnesia, sedative effect that you're getting, and that dissociation are a big reason as to why we're using it, but it's that NMDA receptor that's causing them to have all that. Clinical use, induction, and maintenance, right? So I can use it for both. And then you see also that you can use this to supplement that nitric oxide, so I can help induce them and get some pain relief for our patients if I'm using this medication, okay? Looking at our off-label uses, there are so many things that we're trying to look at using ketamine for. I want you to focus on the things that are up at the top, okay? So depression, anxiety, lots of research are going to go into these, and we do have lots of research that's going into this right now to see kind of how can ketamine help with people who have refractory depression, or they have very debilitating PTSD. We are looking and using ketamine a lot for that. Refractory status epilepticus, so this is somebody who has seizures, and we can't get them out of their that epileptic state with our oral medications. We will sometimes use these, and then our patients who have chronic pain, try to stay away from this, but it is an option that's there. But we'll go to other things first, because this is also an addictive medication. You also see that it's a control medication as well. You will probably use this a lot when we're talking about like the other one that I want you to remember that's not bolded is the one that's up here at the top, the debridement. So especially in the ER, if there is some type of dirty wound that a patient has, and it's very painful because it's open and you need to clean it out, you will see where we will administer ketamine in those situations. Sometimes we'll also give them some if we're changing a dressing. So, as things start to heal and they'll start to stick to those dressings, but when you pull it off, and depending on the surface area that person has that dressing on, we want them to be comfortable while we're doing that, right? So we'll try to give them a little bit of ketamine to help with us doing that procedure so that they're not very uncomfortable. So if you're nice, you're going to want to give them a little bit of ketamine when you do that. This is looking at TCCC, and how you're looking at this. This is one of our primary analgesics that we're going to use. Again, we also get the benefit of that sedation. Don't need you to remember the dosing of this, just understand that it's one of those ones that we're going to use. Talk to you already about making sure that we disarm that patient, right? Because we don't know how they're going to wake up once they emerge. And then looking at the other, the TBI or eye injury, there's a lot of controversy that goes back and forth, and some providers will say, hey, I don't want to use ketamine in these situations. There is not anything that says there is an absolute contraindication for you not using ketamine in those patients. And think about it. If we're on the battlefield, these are the injuries that you're likely to see, okay? So therefore, when you see this, we still use ketamine, okay? Ketamine is a great option for you to use in those patients. Make sure that you are monitoring their breathing, because we can have that respiratory depression occur in our patients who are using this. The higher the dose, the more likely you are to see those side effects that we talked about occur. Let's see if there's anything else from here. And I already told you don't remember the dose. Oh, this is one thing that I want you to look at about the dosing. So sometimes whenever we're dosing this medication, we are trying to, depend on what our end state is, but sometimes you'll have to where we're trying to control their pain. Hey, how is your pain scale now? Like, where are you on the pain scale? So let's say they talked to you initially and they were at an 8, now they're at 3 or 4. Cool, got it. Our med is working. Or if you can't get an actual response from your patient, or if they're still telling you that they're in pain, if you start to see the nystagmus, which is their eyes going back and forth, that's how you know you're done. You can't give them any more of the med. Okay, so you're at your maximum dose for that patient. So it's kind of like we're titrating them to a side effect. Okay, so watch out for that. Our advantages. So if we are, again, put your mind in the battlefield kind of setting, and you're looking at a person who is in some type of shock. Okay, they may have lost a lot of blood and they're now in shock. You see that I have great benefits with using ketamine. I can get my increase in my blood pressure, my heart rate, my cardiac output, like it's gonna bring those things back up, which in that situation I'm gonna need because they're gonna be dropped down, right? They lost a lot of fluid potentially, and so I want these things to go up. Now, with that being said, make sure that you're watching out for your patients who already have an increased blood pressure or an increased heart rate, right? Because now I'm giving them this medication, but it's additive. Now I'm worsening my patient's condition, okay? So make sure that you're getting your vitals prior to administering this medication. Also, you see several other benefits. I can bronchodilate my patient. I can help to maintain their airway if I had to intubate that patient. So, like, very versatile medication. A very good medication for us to use and for you guys to have, because you're going to be frontline. Quick onset, recovery isn't too bad after you take them off, so now I can quickly put you under and then I can move you and I can have you emerge instead of you being out for several, like 12, 13 hours. Like, this is a quick on, and even though 4 hours can be long, and a quick off. But very variable on how they're going to emerge. So that's why we disarm that person, because you don't know when they're going to wake up from what you gave them and that dose that you gave them. Okay. Also, unlike some of our other anesthetics, your ketamine has the properties to also help with pain. Okay, so it's a big benefit of this medication over some of our others. Looking at the rest of our side effects is increased ICP, so the potential to worsen the TBI. So that's what we were talking about previously, where depends on what provider you're talking to as to what they would feel comfortable with, and then that's also going to eventually become your decision as well. Like, hey, what are you comfortable with? That disorientation that they have after their procedure, okay? And that's why, again, we are trying to disarm them, because they could have been in some very vivid, crazy dream, or the last thing that they remembered was being blown up, right? And so they wake up and they're still in that fight or flight mode, but now it's you and it's not an enemy, okay? And then that dose-dependent nystagmus that we talked about, to where we can sometimes dose to, did I control that pain? Or did I cause that nystagmus to occur in my patient, okay? So, when you're looking at your advantages, you're seeing like why this is the first thing typically that you're gonna reach for, okay? Several different ways for you to use it in the way that your patient will present, especially if they're in shock, especially if they're hypotensive. Great medication for us to go to. Propofol. Does anybody know about propofol?
Quite the lines.
Michael Jackson, right? That's where everybody started learning about propofol. So when you look at propofol, we don't completely know the mechanism of action, but when we're looking at this, you see that there is a lot of inhibiting of your GABA. So when we think about this, the longer that a person is on this medication, a big monitoring parameter that you have, think about it as being white and just fatty, right? Like if you had a fatty steak and it got cold, you know how the fat turns white? Your propofol is made of a lipid emulsion. And it is very hard to draw up in the syringe if you have to use it to like make a bag or anything. It is not, I hate seeing propofol come through. But the big thing with this is that this can cause a great increase in their triglycerides the longer that they're on the medication. So after about 3 or 4 days, if you're continuing to run pro, you need to be checking and getting a panel to make sure that you're looking at what's going on with their triglycerides. What does their lipid panel look like, okay? So we're checking because we are worried about triglycerides. We're worried about the triglycerides because of the way that we formulated this medication, that lipid emulsion. Clinical use, induction and maintenance, and then you see that it also is going to help with that pain. This medication can easily be abused, but as you see here, not one that it has to be a controlled medication. So that's how some people have easy access to it. But it is only IV, so you have to have access to have somebody run an IV for you to get the medication, okay? Our advantages, quick on, right? I'm getting to where I need to go very quickly. I'm gonna wear off fast as well, so that quick on and off is what we like sometimes. I also like this because your renal hepatic function, I don't need to dose adjust. I love to not dose adjust, right? It makes it easy for me, I don't have to look anything up, all right? And then that anticonvulsant property, so if some of your patients, you can't have that added benefit if they're seizing, especially if they're in that refractory state to where you can either get them to stop, or if you have somebody who's having TBI, and they can potentially have seizures after someone has a TBI for up to several years after they have it, you have that added benefit of giving them the approach and having the benefit from there. Adverse effect, Michael Jackson, okay? That steep concentration response curve. Why this isn't controlled yet, I don't know. I'm sure it'll eventually come. Maybe they feel like the provider would say, okay, like, no. But you have a high ability to be able to become addicted to this medication, okay? So high probability of that. Your respiratory depression, bradycardia, right? I'm slowing all these things down. So what's different from my ketamine when I'm talking about my propofol is now you see that I am slowing things down versus where I was picking it up when I was looking at my ketamine. So if your patient already has a very high heart rate, this is going to be something that's better for that patient, right? Because I'm not further increasing it with ketamine. So if I had to choose between the two, I'm like, okay, now I need to use prop in this patient because they're already tacky, they're already high. I don't want to increase that with my ketamine, so I have the option now to use my propofol. We also talked about that the triglycerides going up, okay? So that was one that was there that's not under here. We probably leave that there. And then looking at your PRIS or your propofol-induced syndrome. So your PRIS essentially is a happening the longer that you have someone on it. Not a lot of people experience it, but it is something that is not fun because your body essentially starts to fail, okay? You would stop the medication, you'll see hyperkalemia, you'll start to see they're going into acidosis, and as you start to look and you're like, why is this happening? Like, what's going on? Do I have probe running? Have they been on probe, especially if they're on it for a long period of time? You're likely to see patients on this for a longer period of time if they're like in the ICU. Okay, that's typically where you're gonna be running this more often than not. And then my contraindications, again, because of my formulation, if I have a patient that's allergic to soy or egg, I'm going to watch out for this medication because they can have a hypersensitivity reaction to the medication, okay? Because that's how it's formed, that's how we make it. Looking at our dexmedetomidine or or Precedex is typically how you will hear that. We typically use the brand name for that one. Their central and postsynaptic alpha 2. What was my alpha 2 doing? Exciting or inhibiting? Inhibiting, right? So I'm getting more inhibition from this. So when I'm looking at my use, I have, I'm using this in anesthesia. I'm using this for my patients who are on a vent. You will try to, if you're trying to see if your patient can now breathe on their own or you want to get them off of the vent, we kind of manipulate the how we're running it, bless you, and we'll kind of go up and off to like up and down to see like, okay, if I turn this down, is my patient going to try to start bucking the vent? If they buck the vent, it's like, okay, they're trying to start breathing on their own again. If they don't, you know that they're not ready again and we turn it back up. So this is one of those things that you'll typically see in the ICU, especially for your ventilated patients. With this recommendation of not to exceed that 24 hours by the recommendation and what's actually done in practice is a huge gap. You do see this actually happening, but again, most of the time they'll try to like give little rest periods and not keep it running for a long time, but it is something that if they're in the ICU and they're on that vent, you're gonna see it. But practice 5 days, manufacturer says 24 days. You see this onset and the duration, so that's why I like to turn it up, turn it down. Let me see what my patient is gonna do. My advantages, I can have the benefit of helping my patient with their pain, but not giving them an opioid and potentially having them be addicted to this medication, right? So I have my opioid-sparing analgesic. It's gonna help me with nausea and vomiting. It's gonna help me with anxiety. Again, another versatile drug that we have the benefit of using. Look at what's happening to my blood pressure. I have another one that is decreasing my blood pressure, so make sure that you're watching out for that. Already talked about nausea and vomiting. Okay. Adverse effects, looking at your elimination, it's hard for us to kind of predict what the medication is gonna do in our patients, so that's where you see that variable elimination. We still use it because it's a great med. We use it, and the patient is in the hospital anyway, so we're monitoring them to see how they're responding. Looking at your hypertension, bradycardia, tachycardia. Your tachycardia, again, and the bradycardia, like, okay, which one are we doing? It varies on how the patient is responding to this med, and also it depends on how that patient's body is going to respond. Because I could take my patient and then they have reflex tachy, or I could cause tachycardia in that patient, and then I have reflex brady. Also dose dependent on when we're seeing this as well happen, the bradycardia versus the tachycardia. You also see that the faster you run it, the more likely you are to have cardiac arrest occur. So we're not trying to quickly run this medication, bless you, more of a slow infusion that we're trying to do this with, and that's also with our infusion rate affecting how we can see that hypertension occur. So just slow things down. If you start to see that their heart is slowing down, am I running this too fast? If you start to see that they're getting hypertensive, am I running this too fast, okay? And then we have to renally adjust and hepatically adjust for our Precedex. This is just like an FYI slide for you to see all of the different ranges, so don't remember any of these. It's just giving you the meds that we just talked about and kind of how we're using those. Another one that's going to be an FYI slide for people who like to get more background. So this is just an article and looking at how we're using our propofol and some of our IV anesthetics. So nothing that I'm going to ask you about on your exam. All right, our NMBAs, these are literally the same exact slides that you saw already. So what I want you to remember is essentially all of these are not going to produce the same exact effect in every target cell, okay? We are going to get different effects, different responses. They're not, if I use this one, I'm seeing the exact same response in the other, okay? Looking at this and why we would use it, we already talked about this. If I'm intubating somebody, if they're on a ventilator, I'm essentially trying to get them to relax their body to not fight against whatever it is that I'm trying to do to them, okay? No consciousness, they're awake. Consciousness is not affected, pain is not affected, they can feel it. So we are giving them this as a part of our cocktail, essentially, for our general anesthesia, okay? This is taking care of them not moving, this is freezing them, while I have other meds that will knock them out, make them forget certain things, all of the other meds that we talked about before, okay? Non-depolarizing, depolarizing, we talked about this, the fact that these are all gonna be given IV. Looking at our mechanism of action, I just want you to remember that they're NMDAs. I don't need you to go into the phase 1 and phase 2 because we already talked about that. Remember, your phase 1 was like, I'm gonna get those contractions initially, and then after a while, I desensitize it to where they're not gonna move, okay? That was your phase 1 versus your 2. Looking at your RSI or your rapid sequence intubation, as typically while we're using our acetylcholine, our uses, it's very quick, right? The procedure is very quick, therefore I don't need this to last long. So that's why this was our short-acting one, this was our only depolarizing agent that we had. All right, remember that chart. Looking at our PK parameters, again, because it was that very short-acting one, it's not something that's lasting for a very long period of time. It's going on to do what I need it to do, and it's gonna wear off very quickly. When you're looking at this, why we're not giving this as a continuous infusion, that's due to that pseudocholinesterase deficiency that somebody can have. And essentially what's happening is that pseudocholinesterase normally will break down an NMDA. And so if you have them not there and the NMDA is around for a longer period of time, then I could potentially end up having bradycardia, and then I can die, right, if my heart slows down too much, okay? So that's why we're worried about, and that's why we do not give it as a continuous infusion. Looking at our monitoring, our vitals, make sure that they're hooked up, that you're looking at that respiratory rate, that you're looking at their potassium levels. That's also another part of why we're not giving this as a continuous infusion. And then you also see that you have that hyperthermia and then that pseudocholinesterase deficiency that we talked about that could become very serious. We've seen malignant hypothermia before, we're seeing it now again, that respiratory depression, especially if we're on a higher dose for a longer period of time or we're trying to do a continuous infusion, which is a no-no, okay? Looking at your contraindications, because of that malignant hypothermia and the pain that you can get from the hyperkalemia, if somebody already has the underlying muscle pains, I don't want to give this to those patients, okay? I'm trying to avoid it if I can avoid it. My black box warning is going to be that rhabdo, and we'll talk about rhabdo a lot when we talk about like our statin drugs. But when we're looking at this, just understand that you're going to have a lot of, because that potassium level is going up, you're going to see that you're going to experience more muscle pains if that is something that happens in that patient. So when you're looking at your rhabdo, especially if you don't catch it, it is something that could potentially lead to cardiac arrest. It could be something that is very detrimental to your patient. Even when they have rhabdo and you recover them, they're still sometimes hurt, and it takes them a little while to recover from rhabdo. And then your drug interactions, just making sure that anything that can affect your potassium level, so we'll talk about certain diuretics, things like that, we need to make sure that we're monitoring it. Because if something is going to increase those levels and I'm taking it with another drug, acetylcholine, that's increasing those levels, now I have a higher chance of them having rhabdo. Real quick, this was that chart that we looked at already. So remember, I told you to remember your short acting is your acetylcholine. PAN was the long acting because it spreads across, and everything else is in between. Okay? And then we'll start here tomorrow before we finish our review. I had a question about, is it a potential for drugs that, if you don't want to hear about the exam, good, I'm done teaching. I had a question about, will there be potentially drugs on the exam that we have not gone over already? On any exam, yes, that is a possibility. That should also be a hint to you. I never heard this. I probably should pick that. Okay? Like we didn't talk about it. I shouldn't be asking about it. Okay? So there is a possibility that you will see that. The other question that I had was like, if you guys are trying to, how do I say it? Like word associate. Try to also in your brain understand what, like, remember the real name of that drug, okay? Because if you're just like P&P, but you don't know that I'm saying propofol instead of propranolol, I might have an issue, right? Because those are two different things. So will I make up a drug? No. But is it a potential, like I'm not going out of my way to trick you, but is it a potential that like there could be two things that start with a P? Yes. So I want you to not just like say like, oh, it's a drug that starts with a P. There's lots of drugs that start with a P, okay? So I don't want you to just rely on that. I want you to study properly, so that's why I'm telling you this. Don't just look for just, there's something with a P. We talked about a lot of drugs that start with a P. And if it just so happens to be one of those answer choices, you're gonna be like, oh, she tricked me. No, it was just another P, okay? So that was the other thing. And then also, make sure that you guys have your calculators, because when we take the exam on Monday, everything has to come off of your desk. Like everything except for your computers. So that we don't have any confusion, no problems. Does everybody have a calculator that is not one that's on their phone? If you don't, I'm gonna talk to them to make sure that the phone thing is still going to be something that we're good with, because you're gonna have your math problems, okay? But they're gonna make us remove everything. Don't pass out any papers before I get here. I have to pass out all of the papers now. If you don't pass the exam, make sure that you fill out the entirety of the back of your forms, please. Okay, so that means your name, that means put your counselor, don't leave it blank. If you write on your scratch paper, your name also now has to go on that scratch paper too. Okay? They want everything to be, we need everything to be aligned. So if you write a word on there, your name now has to go on there. Other thing, they have their exam on Monday too. So do not wait until the last minute if you have a question while you're taking the exam to ask me, because I may end up being over there at the time that it's over, because I'm gonna be going back and forth. Not like I can tell you anything, I'm just gonna look at you and be like, if that helps you, if that helps you pick the right answer, I'll do it, okay? So like, again, ask me all of the questions that you have as you are studying. I do not mind you texting. Try to look for clarifications before you ask me, right? But if you cannot figure it out, or if you need me to be creative to help you remember it, then tell me, look ma'am, I looked this up, I still am confused, I don't get it, can you help me? Okay? Please text me, because I'm not gonna be on Canvas, I'm not gonna be on my emails, I'm going to be looking at my phone for all of y'all to, if you have a question, to text me, okay? Also, I got you. Also, study, you will be okay. Try to not let nerves get to you. Also, you need to rest. If you do not sleep, y'all, these words will start blending in together, and I'm promising. I stayed up until 4 writing that exam, and the words started blending to me. And I teach it, I do this, okay? So like, just remember the basic things about taking an exam and breathe. We're gonna be okay. We're gonna be okay. Yes.
In past tests, we've been able to use the calculator on our computers if we just raise our hand
Oh.
first.
I'm gonna make, because in the past, y'all could also pass out papers.
Sure, fair.
So I'm just gonna make sure, because we don't have time for them to say we did anything, we didn't do it. So we're going to, I'm gonna clarify that. Typically, we also let you just raise your hand and show me that this is just my calculator on my phone. So we're just trying to remember on that day, take everything down so that we don't have to have that pre-conversation about all of this stuff again. Yes? I'm gonna clarify, because they just told us everything has to be off of our desk, everything. Your pictures, and I'm gonna ask them about like your very desk, like, are you supposed to take that off of your desk? So I'm gonna,
Take it off, we're done here.
Take it off.
Take it off, no Wi-Fi.
no Wi-Fi, stop with the straight face, stop saying it. You can,
I've been at your law, after school.
I know, don't be making me nervous of it, just take it all off, okay? I'm gonna clarify, okay? We gonna make sure that we are good in here. Somebody over here wants to ask something. We good?
There's that. Just sometimes the Wi-Fi pucks don't work, so we
I
have a
know,
hotspot.
and also if those don't work and your phone